Okay, today we are going to talk about diabetes, and today's first lecture is just an introduction to diabetes. It is not detail of the diabetes, this is just an introduction to the diabetes mellitus, right? With little introduction to the diabetes mellitus as a overview. After that, we will shift to the fundamentals, right? We will talk about that how blood glucose level is regulated in a healthy person within normal limits, right? And blood glucose level and role of different hormones, hormonal interplay. There are hormones which prevent the hyperglycemia and there are hormones which prevent the hypoglycemia in a normal person, right? So we will be talking about that too, right? So first of all, how do you define diabetes, right? Before we go that, I want to tell you that it's something very serious. You know, every 5 seconds, one person in the world is dying due to acute or chronic complications of diabetes. Again, it's worth repeating. It's such a serious disease that every 5 seconds, one person in the world is dying due to this disease. I always say that rather than saying that someone died of heart attack, sometimes we should write this man died due to, due to complications of diabetes, because many of the myocardial infarctions and or end stage renal disease or different type of strokes, right, they may be induced due to as a complication of diabetes mellitus, right? So actually we can say that so many people die due to complications of diabetes mellitus, right? Now, what is really diabetes? It is not one disease, it is not single disease, it's a group of many diseases, right? And all of them are lumped together in a bag. Again, I will say diabetes mellitus is not one single disease, right? It's a metabolic derangement in our body. This is a group of metabolic diseases, and this group of metabolic diseases are put together due to certain commonalities. Now, what are the commonalities? Common thread in all the diabetic patient is tendency for chronic hyperglycemia. What is that? Tendency for, yes, chronic hyperglycemia, right? This is one thing. This is a common thread, right? Or we can say that this thread is, yes, this thread, if this, I call this hyperglycemia, this is a death string, chronic hyperglycemia, right? Now, second thing which is important in this group of disorders is, number one, yes, either there is reduced insulin production or there is resistance to the action of insulin, action of insulin. So we can say that all those patients who are called suffering with diabetes mellitus, remember, whenever I say diabetes onward, I mean diabetes mellitus, because there is another condition which is called diabetes insipidus. That is entirely different disease that is not characterized by hyperglycemia. Diabetes insipidus is a condition in which there is polyuria due to reduced production of antidiuretic hormone or reduced action of antidiuretic hormone. We will not be talking about diabetes insipidus, we will be talking about diabetes mellitus. And when I talk about diabetes mellitus, I will just mention onward diabetes. So whenever I said only diabetes, it means diabetes mellitus. What I said up to now, in diabetes mellitus, it's a group of diseases. Common thing in all of them is hyperglycemia. And in this hyperglycemia, what is there? either there is reduced production of insulin or there is increased resistance to the action of insulin. Let me put it here. If this is pancreas and here are the beta cells and they produce insulin, right? And that is going through the blood to the cells and acting on its receptors, right? Now, either there is reduced production or there is reduced action, right? Or any combination of both things, that in some of the types of diabetes mellitus there is reduced production as well as there is increased resistance to the action of insulin. Is that right? Now we come back. Let's make it right. Let's make it diabetic monster, right? In this diabetic monster, right, we'll put it here. This is our death string. Here there is reduced production of insulin, and here what is there? Increased resistance to insulin, right? And in this death string, in this group of diseases, there are many different types of diabetes. For example, yes, the classical example in which there is reduced production of insulin is type 1 diabetes. That is type 1 diabetes mellitus, right? In this case, of course, we'll discuss type 1 diabetes in detail in future. But right now, what I'm saying, the type 1 diabetes mellitus is a classical example in which there is severe reduction in production of insulin. Why insulin is so less produced or sometimes absolutely absent? Because beta cells which produce the insulin, they have attacks by the immune system and destroyed. Or we can say that beta cells of pancreas are destroyed due to autoimmune reaction. This is one example. Then on the other extreme, we can put type 2 diabetes. In type 2 diabetes, the major problem is resistance to the action of insulin. At least in the initial stages of disease, what is happening, that beta cells of pancreas are there. They might be producing insulin in normal level or even more than normal, but cells are not responding to insulin, right? Cells become deaf to the insulin, right? So these are the two extreme cases, type 1 diabetes and type 2 diabetes. Classical thing in type 1 is there is absolute or very, very dangerous reduction in production of insulin due to autoimmune destruction of beta cells of pancreas, right? In type 2 diabetes, what we say classically in this case, what happens, that there is insulin is being produced at least in the early phase of disease, right? Because this disease goes for many years or over decades, right? So at least in the beginning of the disease or early stages of the disease, insulin is being produced. The real problem is in the beginning that tissues are not responding to insulin. Is that right? So these are the only two conditions or two diseases. Then there are more diseases, type 1, type 2. After that, I can say, okay, someone said gestational diabetes. Okay, we put here gestational diabetes. Gestational diabetes mellitus or diabetes. What is this? This is a condition in which during the pregnancy there is tendency for hyperglycemia or there is hyperglycemia. Is that right? We will discuss in detail later. But what happens in gestational diabetes? In this case, there is problem in production of insulin as well as there is peripheral resistance, that tissues are not responding well to the insulin. Then there is another condition with very interesting name. We call it LADA. Okay, who will tell me? LADA stands for what? Latent. Yes, L stands for latent autoimmune. Yes, diabetes of adults. Okay, let me tell you now interesting thing. If I talk about all the patients in the world who are suffering with diabetes mellitus, and if those patients are having real problem is underlying production of insulin, right? Most of them will be youngsters, type 1 diabetes. But if you find a man who is 40-year-old, right, a man 40-year-old or 50-year-old, and autoimmune process destroys his beta cell, which is less often, right? So actually at a very late age, he has developed autoimmune destruction of beta cell, so his condition will be somewhat similar to type 1 diabetes. So such patients are called not type 1 diabetes, because usually this is seen in younger patients, because this is very late onset of type 1 diabetes like disease. This is late onset of type 1 like disease, but very late onset, so we call it LADA, right? Basically both are similar condition, autoimmune destructions of beta cells. Then I would put, rather than putting gestational here, I will put gestational little down, and again I will put something which is very similar with type 2, right? Which is very similar with type 2, but develops at younger age. Again, type 1 classically develops in younger age, type 2 classically develops in older age. Everyone knows that. Every good doctor knows type 1 diabetes is at younger age and type 2 is at usually later age. But if someone develops a disease like type 2 diabetes but at younger age, is that right? For example, someone has diabetes mellitus in the age of 20, but his real problem is not beta cell destruction, his real problem is increased resistance to the action of insulin, right? It means insulin is there but is unable to produce its action. Insulin is there but unable to produce its action. So that disease, but if it starts at very young age, classically it should start at older age. If it starts at younger age, we call it maturity onset diabetes mellitus, right? Or we just call it MODY. MODY stands for maturity onset diabetes of young people, right? Again, I will repeat and I will see who will tell me the right answer. First of all, we talk about the two extreme. This common string is hyperglycemia. Is that right? This is the death string and it has many death stones. It has many death stones. Death stones mean different types of diabetes, right? One extreme is type 1 diabetes, in which real problem is under severe reduction in production of insulin due to autoimmune destruction of beta cells. Other extreme is that there is problem with the action of insulin on the peripheral tissues, right? And at least initially insulin is present in the patient's blood. Gradually it might decrease. So this is type 2 diabetes. So classically, doctors, a good doctor usually knows about type 1 diabetes and type 2 diabetes. Then of course there are some doctors which are very good, right? If we talk about very good doctor, he will be aware of some slightly different situations. Very good doctor should be aware of that sometimes you might come across a patient who has diabetes mellitus. Sometimes as a doctor or as a nurse, you may come across a patient who has diabetes mellitus and it is at adult age, but this diabetes mellitus is behaving like type 1, like as if there is severe deficiency of insulin production. Real problem is, or at least initially, the real big problem is not peripheral resistance. So we'll call it LADA. What is that? Latent autoimmune diabetes of adults. Is that right? So another way we can say the real difference in type 1 and LADA is, one difference is that both of them are due to extreme deficiency of insulin, but one is at younger age and other is at adult age. Now we come to the other end. Every doctor knows about type 2 diabetes. Is that right? And every doctor knows that most of the type 2 diabetes patients are at older age, usually 35, 40 plus. But if you come across a very young person, right, and that person is having a type of diabetes mellitus which is behaving like type 2 diabetes, it means this person is having maturity onset diabetes, but in a young person. This person is having maturity onset diabetes, but in a young person, right? So we can say we have talked about 4 types of diabetes. Now we come to 5th type of diabetes we have already discussed, and that was gestational diabetes. Gestational diabetes mellitus or diabetes. Then gestational diabetes is easy to understand. Of course, all of you must be knowing this is only limited to the females. Okay, gestational diabetes. Then there is another type of diabetes which may be secondary to some situation, right? For example, if I take some drug and that drug produces hyperglycemia, and if I am taking that drug chronically, if I am taking that drug for a long time, right, then what will happen, that I will have a tendency for chronic hyperglycemia, and we say that there is drug-induced diabetes mellitus, right? So such kind of diabetes mellitus, right, they are called secondary diabetes mellitus. There are so many types of secondary diabetes mellitus, but just as an example, we talk about one drug. A very commonly used drug is beta blockers. Beta blockers, classically propranolol. Now, propranolol, it blocks basically beta receptors, right? And on the pancreas, in the islet of Langerhans, on the beta cells, there are beta 2 receptors, right? This is pancreas, here is your beta cell, and on the beta cell, there are, yes, this should be 7-pass receptor. This receptor is basically beta 2 adrenergic receptor. Is that right? Now, what happens that if we give beta blocker, this receptor is not functioning, right? There are alpha receptors there too. If these adrenergic receptors are not functional, right, insulin will not be released properly. There will be dysfunction in production and release of insulin, and person will develop a tendency for chronic hyperglycemia. So we will say this is an example of secondary diabetes mellitus. Another example we can take drug like thiazides. Patients who are for long term on the thiazides, it's diuretic, that can also produce picture like diabetes mellitus, right? Then we can talk about some endocrine disease like Cushing syndrome, where chronically there is elevation of cortisol hormone, right? And when cortisol hormone is high chronically in your body, yes, cortisol hormone and glucose metabolism. What cortisol is doing, or steroid hormones, right? What they are doing to your body. As far as metabolism is concerned, they produce catabolism of the proteins, they produce lipolysis, breakdown of the lipids. So, breakdown of adipose tissue and lipolysis produces free fatty acids, and amino acids are also broken down due to catabolism of the proteins, and both of them, free fatty acids and amino acid or their derivatives, they are supplied to the liver, and in the liver steroids increase the process of, yes, gluconeogenesis, and liver start producing glucose, right? So what we can say, in Cushing syndrome there is a tendency, even in acromegaly and some other endocrine diseases, there is a tendency for hyperglycemia, and such hyperglycemia is called secondary hyperglycemia. So what did we learn up to now? We just learned that diabetes is a dangerous disease, and every fifth second it is killing one person. Globally, about 500 million people are suffering from it. Globally, about 500 million people are suffering with the diabetes mellitus, and in USA they say there are about 36 or 37 million people suffering with diabetes mellitus. So when we talk about diabetes, it puts a lot of global load. There's a lot of morbidity, there's a lot of mortality related with it. I would say diabetes is a monster. Every year, how many people die due to this disease? Who will tell me? About 60 to 7 million people. 60 to 7 million people die of diabetes. So I must say that this is basically diabetic monster. And this diabetic monster, with a death string of hyperglycemia, having death stones in it. These death stones are different types of diabetes with two fundamental underlying process. Either diabetes is not being produced, or insulin is not being produced, or insulin is unable to produce the effect on the tissues, or both problems might occur, right? And type 1 diabetes, insulin is not being produced, and type 2 diabetes, what is the real thing? Insulin, at least at the initial stages, initial years of the disease, insulin is being produced, but tissues are not responding to insulin, right? Then we talked about other types of diabetes, right? Now how diabetes kills? How diabetes kills? Due to its dangerous complications, right? As I told you, our first lecture is not diabetes in detail. I will talk in detail later, but let's talk about this monster and this monster's complications. Okay. First of all, we should know this is very dangerous. This diabetic monster, if unfortunately, let's suppose we imagine a person who has diabetes for a long time. He has diabetes for long time. There's not only chronic hyperglycemia, because a simple doctor, an innocent doctor, thinks diabetes disturbs carbohydrate metabolism, right? But the real doctor knows that even though main problem is hyperglycemia, but actually secondary to the insulin failure, not only hyperglycemia occur, not only carbohydrate metabolism is disturbed, but protein and lipid metabolism is also disturbed severely. So what we can say in this monster, okay, this I don't know how to make it look very angry, but in this monster, a simple and innocent doctor will think that carbohydrate metabolism is disturbed. But actually, yes, what is there? Lipid metabolism is also disturbed and protein metabolism is also disturbed. Of course, we will discuss all these disturbances in the metabolism later, right? In later lectures. But up to now, what is diabetes? It's a group of diseases, metabolic diseases. The common thing is hyperglycemia due to decreased production or decreased action of insulin or any combination of this, and eventually it disturbs not only carbohydrate metabolism but protein metabolism and lipid metabolism also, and I will definitely explain these things later. But because it is just fundamentals of diabetes, let's talk about what are the real problems with the patient, right? Number one, diabetes can produce vascular problems. Some people think it should be considered a disease, vascular disease with many other complications, right? So when we talk about that diabetes damages the vessels, right? The vascular disease or angiopathy which occurs in the diabetic patient, we divide them into two types: big vessel disease and small vessel disease. Why we say big vessel disease as a separate group, small vessel disease as a separate group? Why we differentiate? Because underlying mechanisms are different. Diabetes produces big vessel disease, which is called macrovascular complications, macroangiopathy, or macrovascular complications, or we can say big vessel diseases in diabetes mellitus. And then it also produces small vessel disease, right? And that is called microvascular complications or diseases. Now, microvascular means smaller vessels. Classically speaking, capillaries, but actually, true definition of microvasculature is, it starts from the arterioles, it includes the capillaries and then venules. But diabetes mellitus specifically and classically damages the capillaries a lot, right? So there are some complications in diabetic patient due to damage to the small vessels, and there are other complications which are due to damage to the big vessels, large vessels. Large vessels mean elastic vessels. Elastic vessel classically your aorta or muscular arteries, right? So bigger vessels, large vessels or mid-size vessels. Now, what are the complications it produces? Number one is coronary artery disease. Coronary artery disease, right? Let's suppose if I talk about atherosclerosis in coronary artery disease, right? Now, what really happens? You must be knowing that this macrovascular disease is not specific and limited to diabetes mellitus. It does occur with aging, it does occur with hypertension, it does occur in the patient with hyperlipidemias, and of course, it can occur in patient with diabetes mellitus, or there are unfortunate patients who have multiple factors, a patient who has diabetes mellitus, a patient who has hypertension, patient who has unfortunately hyperlipidemias too, right? So he will develop coronary artery disease. Is that right? But if you have diabetes, coronary artery disease behaves very aggressively as compared to other causes of coronary artery disease. Let's suppose there's a person who has hypertension and here's a person who has diabetes mellitus, severe uncontrolled diabetes mellitus. Patient with hypertension only and patient with diabetes only, both of them will develop the atherosclerotic disease or multiple atheromas, right? But in patient with diabetes mellitus, atheromas will be more severe, more diffusely present and at earlier age developing. For example, if someone has uncontrolled hypertension only, he might develop, once he develops the hypertensive condition, he might develop, let's suppose, he takes 10 years to develop dangerous atheromas. But if someone has diabetes mellitus, within 5, 6 years, 7 years, he will develop very dangerous atheromas. So what I'm trying to say, that atherosclerotic disease or atheromas in patients with diabetes, they are more bigger, they are more diffusely present in the vessels and they appear earlier. Is that right? So we can say that macrovascular disease, when it appears as a manifestation of coronary artery disease in the presence of diabetes, disease is accelerated behavior and more severe behavior and dangerous behavior, right? Coronary artery disease, of course, it means in the patients with diabetes, if I say coronary artery disease is more common, what I really mean by this? Of course, they have stable angina, more common. They have unstable angina, more common. They might suffer with myocardial infarction, more commonly. They might suffer from sudden cardiac death, more commonly, right? I always think that someone who has diabetes and dies of the myocardial infarction, I think on the gravestone it should be written, this gentleman died of the complications of diabetes, not just MI, just to increase the awareness, right? So what I said, that in coronary artery disease is one of the manifestation of microvascular complications and they develop in the patient very commonly, right? I always say, I will go to the other complication. Let's talk about another macrovascular complication, that is cerebrovascular complication. Cerebrovascular complications. Cerebrovascular events or cerebrovascular accidents. What I mean by this, that in patient with diabetes mellitus, large vessels or medium-sized vessels, either they are related with the heart or with the central nervous system, they develop what kind of disease? Atherosclerosis. They develop macroangiopathy. What is diabetic macroangiopathy? Number one, diabetic microangiopathy, macroangiopathy is not limited to diabetes only. This can occur in patients with hypertension, in patients with hyperlipidemia or with advanced aging. But once it occurs with diabetes, it occurs very rapidly, very severely, and it is more aggressive. So cerebrovascular accidents, CVAs related with diabetes, they are very common. And again, CVAs can be stenotic, that reduced blood flow to some part of the central nervous system due to narrowing of the vessel because there is an atheroma and that if that atheroma is stable, but that has made the vessel narrow, we can say there is stenotic cerebrovascular disease, or there can be thrombotic, that at the top of atheroma, collection of, you can say, platelets and fibrin, right? They make a mass and make the vessel very narrow, may occlude the vessel and produce severe ischemia to some part of the central nervous system, right? So in that case, we say that patient has developed thrombotic CVA. Of course, in patient with diabetes, this is more common. Then we can come to embolic events. Embolic events mean that maybe thrombus formed in the heart, in the left ventricle, and piece of a thrombus break down and it moves through blood vessels and goes to central nervous system and block a vessel there. So this is actually embolus. Or patient has in carotid vessels, patient has very severe atheroma, at the top of carotid atheroma, platelets and fibrin aggregates occur, and we can say a thrombus form here, and that thrombus detaches from carotid vessel and goes upward to the cerebral circulation, and let's suppose it blocks the middle cerebral artery. Of course, it will produce a very severe CVA, cerebrovascular accident, and that will be considered embolic. Again, I will repeat, if due to diabetes, a vessel in the central nervous system become narrow, right, we'll say there is, and that lead to severe damage to central nervous system, that is stenotic CVA. Or there is the atheroma in the central nervous system, and over the atheroma, platelet plug or thrombus form locally, and this thrombus grows and closes the vessel. We'll call this condition thrombotic CVA. Or maybe carotid artery, or from left ventricle, or from any other major artery, some thrombus flows to the central nervous system, right? That thrombus which has detached from its origin, and it is moving. If it is moving, it is no more thrombus, it is embolus. And if that damages your central nervous system, we say that there is embolic CVA. Now, in patients with the end, then there can be, of course, we should not forget hemorrhagic CVA. There can be hemorrhagic CVA also. In hemorrhagic CVA, of course, there is some vessels in the central nervous system, and in that vessel, very severe form of atheroma develop, and that atheroma damages not only intima but also damages the media and serosa so much that vessel ruptures. If that vessel rupture, right, larger size vessel, that might produce hemorrhagic CVA, right? So in patient with diabetes, again we come back, there can be microvascular diseases, there can be macrovascular diseases. When we talk about macrovascular diseases, what happens? We should really focus on coronary artery disease, which might clinically manifest as stable angina or unstable angina, or myocardial infarction, or sudden cardiac death. Then we should talk about other very important organ, central nervous system. If one of the major vessels in the central nervous system undergoes malfunction, if local thrombus is formed and making the vessel very narrow, we say stenotic CVA. If local vessel is having atheroma, we can call it dangerous, unstable, malignant atheroma, very dangerous atheroma, and this is so dangerous that it is not only destroying the intima, it is destroying the media and also serosa, right? And at the top of that thrombus, atheroma, if platelets and fibrin and thrombus form, then what we will say there is thrombotic. And if that a thromba ruptures, right, then hemorrhagic. Or if a thromba is somewhere else, right, and thrombus form over that, for example in carotid, and then thrombus detaches and becomes embolus, and this embolus is moving in the central nervous system and eventually it blocks one of the major vessels, we call it embolic. And if someone asks you what kind of CVA is most common in patient with diabetes mellitus, you must say ischemic CVA. What you should say? Ischemic CVA, which is classically either thrombotic or embolic. Right? Thromboembolic or thrombotic or embolic problem. Is that right? Thromboembolic disease in the central nervous system producing CVA. So diabetes has so many ways to kill you. It can kill you by producing heart attack, myocardial infarction. It can damage you by producing what? Yes, what is this? Producing CVAs. Then it can, okay, can you tell me some more large vessel disease? Yes, doctor? Peripheral vessel disease. Peripheral vessels disease we should not forget, especially in the lower limb, especially in the foot, in the femoral arteries or popliteal arteries or even more distal arteries, right? In patients with diabetes, very aggressive and very unstable, and in big number athromas develop as compared to the normal population, right? And those athromas contribute to the diabetic foot disease, because due to those athromas or athromas with overlying thrombus, right, or embolus, that may lead to ischemia to the foot, right? We call it foot vasculopathy in diabetic patient. So peripheral vascular disease can be there, right? And classical example is that blood flow in the lower limb in the patient with diabetes may be reduced due to complications of macrovascular, yes, macrovascular disease in lower limb vessels. This peripheral can develop in upper limb, but less often. But one thing I should not forget, large vessel disease. I've told you about coronary, I've told you about cerebrovascular diseases, I've told you about lower limb, but one special type of macrovascular disease or complication which develops in patient with diabetes is not to be forgotten. You know what is that? That is related with the kidney. Most of the doctors remember that kidney disease, kidney diabetic disease is microangiopathy. Yes, I agree to that. But major vessel which supplies the kidney, renal vessel, that can develop athromas, multiple athromas, dangerous athromas, unstable athromas, athromas with thrombi, which may even have emboli. So we call it, yes, that macrovascular disease or in the renal vessel, or we simply call it diabetic renovascular disease, right? Again, in a very short way I can say that diabetes can have so many complications. I was just focusing on some of the macrovascular complications, and we talked about that all of them are due to accelerated and more severe atherosclerosis in major vessels, important vessels like coronary vessels or cerebral vessels, or especially in the foot or renal vessel, right? Then we come to other group of complications, right? And this is microvascular complications in patients with diabetes. Small vessel disease. Up to now I told you only large vessel disease. Now I am going to tell you small vessel disease. Now here I want to say something very special. The small vessel disease, which is also called the diabetic microangiopathy. What is it called? Diabetic microangiopathy. This diabetic microangiopathy is specific to diabetes. What I mean by specific to diabetes, that it only occurs in patients with diabetes mellitus. Again, I will repeat. When I said that there is macrovascular disease that can develop in diabetes, but macrovascular disease can also develop in non-diabetic patients. But when I say microvascular disease, a very special type of microvascular disease which specially involves the capillaries, that capillaries basement membranes become very thick. Capillaries basement membrane become very thick because their proteins are altered, because there is non-enzymatic attachment of glucose or glucose products with those basement membranes, and those membranes proteins are altered. Even though microvascular capillaries basement membrane become thick, but they also become more leaky. They are thick but with cracks. They are thick basement membranes of the capillaries but having a lot of cracks. Due to that reason, they are very, very leaky, right? From blood, plasma proteins leak out through those basement membranes, right? So don't think that if basement membrane is becoming thick, it is actually becoming strong. It is becoming thick, but because it is thick due to pathological alteration in its proteins, collectively we call such altered proteins ages. What is it? Advanced glycation end products. Advanced glycation end product, that in the micro vessels, in small vessels, what really happens? Basement membrane become thick. Initially this process is reversible, but over the time it becomes irreversible because these abnormalities become very stable. Is that right? Now, classically and clinically, if we talk about diabetic microangiopathy, there are few organs which should come to your mind. Okay, let's start from the top. Number one is diabetic retinopathy. Remember, in patients with diabetes, some other complications can occur due to diabetes, like cataract, but that is not microangiopathy, right? That I will discuss later. What happens that microangiopathy develops in the blood vessels of retina, right? That retinal vessels develop thick basement membranes, and those basement membranes are not only thick, but they have a lot of micro cracks, and through those cracks, lipoproteins or lipids or proteins, they leak out into retinal neuronal tissue and damage it, even produce microhemorrhages, right? So that can end up, I will say, these complications. What did I tell here? One very dangerous situation, microangiopathy. Yes, retinal, right? That is microangiopathy in the retina. We simply call it retinopathy. Which retinopathy? Diabetic retinopathy. Later on in lectures, in the future, I will tell you how to differentiate diabetic retinopathy from hypertensive retinopathy. This is very important as a doctor to know. You know, retinal vessels are the only vessels in the body which you can look directly in a healthy person. There are no other vessels you can look directly, right? So, when you do look at the retinal vessels, right, you can, in diabetic patient, you can find abnormalities there, right? I will teach you later. There will be a full lecture on diabetic retinopathy, but right now I am telling you there's two types of diabetic retinopathy. At early stage, it is not having proliferation of small vessels. It's not having neovascularization. But when diabetic retinopathy, it becomes advanced. What happens? That new vessels sprout, new vessels grow, right, in the retina. And don't be happy every new vessel is good. Everything new in life is not good. I have some experiences. Yes. So these new vessels which develop in the retina, even though the bunch of vessels, we call it, what we call it? Diabetic proliferative retinopathy. What we call it? Diabetic proliferative retinopathy, which occurs at advanced retinopathy. These newly formed proliferative vessels or neovasculature, this is super leaky. We don't want vessels to be super leaky, right? And when they leak there a lot, they leak a lot of inappropriate substances which should be limited to the blood, but unduly lot of proteins or lipids, they come into neuronal tissue of the retina and produce a lot of complications. We'll talk those things later, but right now you just remember that one of the most important cause of blindness is diabetic retinopathy. And now you are going to tell me without thinking, is it a macrovascular disease or microvascular disease? It is microvascular disease. It is microvascular disease, microangiopathy, right? Number one. Number two, after the eyes, another tissue which loves to have this angiopathy, that is nephropathy. Your kidneys. You know, in kidneys, you have millions of, about 1.2 million nephrons in each kidney. How many nephrons? 1.2 million. As I say in some lectures, that you are millionaire as long as glomeruli of the kidneys are concerned, right? About 1 million to 1.2 million nephrons you have in each kidney, right? And in every nephron there is a bunch of capillaries which are called glomeruli. Those glomerular capillaries, also loves to develop microangiopathy in diabetic patient. I think they love too much sweetness because their, what are these things? Glomerulus. The glomerulus, there are glomerular capillaries, and capillaries are having some substance in between which is called mesangium. So this capillary, their basement membrane and their mesangium, all of them develop advanced glycation products, and that will lead to what thing? That will lead to damage to the glomeruli. And over the years, damage to the glomeruli become, what do you think? This will affect more right kidney or left kidney? Yes, doctor. Both kidneys, of course. It is hyperglycemia which is damaging. Of course, whatever hyperglycemia is occurring in vasculature of right kidney, same is on the left. So this microangiopathy which develops in the blood vessels of the kidney, classically in the glomeruli, even though they can develop in peritubular capillaries also, right? They produce dysfunctional, what is this? They produce dysfunctional glomeruli, and over the time, over the years, over the many years, if patient is not taken care properly, this angiopathy becomes so advanced that glomeruli stop functioning and person enters into end stage renal disease. And in USA, the most common cause of end stage renal disease is diabetes, diabetic nephropathy. So what I'm trying to say, that this disease has so many faces to kill you. It can kill you by myocardial infarction or sudden cardiac death or cerebrovascular accident, or it may kill you over many, many years. I say this disease loves to kill its patient inch by inch. This disease, this monster of diabetes loves to kill its patient in many different ways and over the many years and inch by inch. I told you there was death string of hyperglycemia with the death stones, different types, and this death monster has macrovascular complications and also having microvascular complications. And when we talk about the macrovascular complication, I know I am repeating, it's worth repeating that we have that patient may suffer with the heart problems or brain problems, central nervous system problems, or renovascular disease or foot vasculopathy, right, peripheral vascular disease. Then it can, if it does not kill, at least it can make you blind. That is also very miserable situation, you know. There are so many beautiful things in life which you cannot see if you are blind, right? So it can produce blindness by diabetic retinopathy. That is an example of microangiopathy. Then we talk about diabetic nephropathy. Now here, what is this? Macrovascular disease. But in glomeruli, it is microvascular disease. In glomeruli, it is microvascular disease. And again, I will repeat, one of the most important cause of end-stage renal disease, especially in the advanced country, that is diabetes mellitus. Because in poor country, unfortunately, many patients die due to pyelonephritis, right? Then we come to another, that there is one more tissue which loves to have microvascular disease, that is your neurons. We call it diabetic neuropathy. Diabetic neuropathy. What is it? Diabetic neuropathy. So we have talked about diabetic retinopathy, diabetic nephropathy. We are going to talk about diabetic neuropathy, and all of them may involve what? Pathology in small vessel, microvascular diabetic disease, or we call it microangiopathy. Is that right? Now, let's talk about neuropathy. This neuropathy, it occurs in different forms in patients. One of the common manifestation is peripheral neuropathy, peripheral polyneuropathy, most commonly in lower limbs, right? In the lower limbs, the neurons, especially sensory neurons, they may undergo dysfunction, right? But not only sensory, motor neurons can also suffer. Now, if sensory neurons initially involve the lower limbs or feet, usually they develop symmetrical disease. Whatever is on the right side, same is on the left side. Sensory problem, paresthesias, hyposensation or hypersensations, right? Paresthesias, tingling, pins and needle, and later on they may involve the hands. That is why diabetic neuropathy is one of the example of polyneuropathies, peripheral symmetrical polyneuropathy, also called gloves and stocking disease, because gloves area and stocking areas, this is not stocking a girl, this is, I mean, that stocks, right? So what I'm talking about, that these diabetic neuropathies, first of all, I talk about what kind of neuropathy? Polyneuropathy. What kind of polyneuropathy? Symmetrical. Symmetrical means whatever is happening to the right side of the body, similar neurological damage is occurring to the left side of the body. And classical example of this is, yes, gloves and stocking. And this also contribute to the diabetic foot disease. This also contribute to diabetic foot disease, because as I told you previously, macroangiopathy in the lower limb produces ischemia to the foot. They contribute to the ischemic damage to the diabetic foot. But if sensory nerves are damaged, then patient might get little bit injury and ignore it, and that area may become later on infectious, and infection may spread, and this little problem, yes, this little problem might end up eventually into amputation of the some part of the lower limb. Is that right? Diabetes is one of the commonest causes of amputation of adult lower limbs, non-traumatic, right? Of course, you can get amputation if you really want. There are so many ways. One of them is accidents, trauma, but non-traumatic amputations of the lower limb most commonly occur in the patient, are done most commonly in the patient which are diabetic. Why? Because diabetes monster attacks the foot in many different ways. I don't know, this is very bad. It loves to damage our heart, loves to damage our brain, loves to damage peripheral vessels, and then it attacks the small vessels and loves to damage the retina, loves to damage the kidneys, and now it is attacking the neurons. So in lower limb, if sensory neurons are dysfunctional, that will lead to less awareness of trauma to the lower limb. And if motor neurons are damaged in the lower limb, then person will develop abnormal mechanics of joints and muscles. Abnormal mechanics of joints and muscles that may produce inappropriate pressure points in the lower limb, especially on the sole, and that might produce, yes, already blood flow is less. At the top, neuronal sensitivity is less, and then there are abnormal pressure in some areas of the sole that will produce damage and ulcers there. And here I must mention that when we talk about the neuropathy, about the foot, and we talk about the vasculopathy is macrovascular and neuropathy is microvascular, right? And later on I will tell you, in diabetic foot there is also tendency of increased infections, right? Later on, much later on, we will have a full lecture, 1 hour lecture on diabetic foot. But let's come back. So we were talking about neuropathy, polyneuropathy, symmetrical polyneuropathy. If it is in lower limb and upper limb both, then it is gloves and stocking distribution. But some diabetic patients develop mononeuropathy also. Some diabetic patients develop mononeuropathy also. And mononeuropathy, it means that there is isolated nerve damage that might not be symmetrical. For example, if I develop my oculomotor nerve damage, or I develop damage to the abducent nerve, right? Now, if isolated abducent nerve damage is there due to diabetes, right? Abducent nerve is 6th cranial nerve which supplies the lateral rectus, right? Now, that is also neuropathy, but because one nerve is affected and other nerve is not affected, right? Or on one side median nerve is affected and other side median nerve is not affected, then we cannot say that this is symmetrical disease. This asymmetrical nerve damage, if it is one single nerve, we say it is mononeuritis. This mononeuritis can occur in the sensory nerves and also can occur in motor nerve. Then we come to another condition, that let's suppose you come across unusual patient who has abducent nerve damage on right eye and oculomotor nerve damage on the left side. Very unfortunate patient, develop median nerve damage to right side and radial nerve damage to the left arm. What do you think? It is polyneuropathy?
No.
It is not symmetrical polyneuropathy. It is still mononeuropathy at multiple places. It is mononeuropathy at multiple places. Because when we are saying polyneuropathy, then there should be symmetrical involvement. But if one side is abducent nerve damage, other side is, yes, oculomotor damage, one side is median nerve damage, maybe other side is radial nerve damage, One side is sural nerve damage in the leg, other is peroneal nerve damage. So these are not polyneuropathies. These are mononeuropathies, but at multiple places. This condition is also called mononeuritis multiplex. Multiplex, you know, like cinemas, multiple screens. So multiple nerves are involved. We call it mononeuropathy multiplex. Then we come to another condition, that unfortunately this not diabetes microangiopathy not only damages the sensory and motor neurons, it can attack the autonomic nervous system also. It can attack the autonomic nervous system also. And if it damages the autonomic nervous system, right, there will be other problems. For example, if autonomic supply to the heart is damaged, right, then variation of heart rate will be reduced or increased? Variation will be reduced. Variation of heartbeat, beat to beat variation will be reduced, because if you have healthy autonomic nervous system controlling your heart, then of course adrenergic supply or noradrenergic supply, that increases the heart rate, and cholinergic supply decreases the heart rate. But if both of them are dysfunctional, increase and decrease in heart rate will not be showing variability, right? So heart rate variability will be reduced. Then in such patients who have autonomic neuropathy, they may develop orthostatic hypotension. What is orthostatic hypotension or postural hypotension? That from lying down position, for example, here you are, I hope you are not red-headed, but anyway, here you are lying down or sitting, and if first normal, you are normal person lying down, and due to some reason you suddenly stand up. What should happen? That blood should fall to the lower part of the body due to gravitational effect. But lower limb vessels immediately contract. When from lying down position, a healthy person suddenly stand up or sit up, we expect that blood, due to gravitation effect, blood should pool in lower part of the body, and there will be more venous pooling in lower part of the body. And if there is more venous pooling in lower part of the body, less blood is returning to the heart, and cardiac output become less, and that may lead to blackouts, and your blood pressure may fall down significantly. But in normal healthy person it does not happen. Why? Because whenever you change your position from lying down to standing up, there is a burst of sympathetic activity to the vessels in the lower part of the body, and lower part of the body vessels constrict and squeeze the blood so that it does not pool into lower part of the body, and there is appropriate return to the heart, and cardiac output is reasonably maintained, so that you don't develop vertigo or you don't develop blackouts or complications like this. You are understanding? But if there is a patient with diabetic neuropathy and diabetic autonomic neuropathy, and that autonomic neuropathy is damaging the neurons, sympathetic neurons to the blood vessels, patient may suffer from orthostatic hypotension or postural hypotension, because from lying down position, when he will stand up, sympathetic nervous system is not working and vessels will not squeeze, right, and blood will not be returned properly to the heart. It will pool into lower part of the body, and venous return will be less cardiac output, and when there is less cardiac output, patient may develop vertigo, even blackouts, right? Then this autoneuropathy may involve the autonomic nervous system to your gastrointestinal system, right? If your gastrointestinal system is affected, right, GIT motility will become abnormal. You know, vagus nerve, which is the classical example of parasympathetic nervous system. Vagus nerve is motor to GIT. If this vagus nerve develops, it has lot of what type of fibers? Autonomic fibers, right? Vagus nerve. If vagus nerve develop diabetic macrovascular or microvascular? Yes, microvascular, very good. Microvascular disease, vagus nerve develop, the motor nerve to the gastrointestinal system fails, and might be it will have multiple complications. One of the complications may be that this failure of autovagal supply to the stomach may contribute to a condition called gastroparesis. What is that? Gastroparesis. That stomach as movement is weak and feeble, right? We call it gastroparesis. Then there are some very unfortunate, I think, situation in some diabetic patient, that autonomic nervous system going to the urogenital system is damaged. That may lead to urinary retention because autonomic nervous system plays a major role in urination. Is that right? Actually, cholinergic system help the vasculature of what is this urinary bladder to contract. So if it does not contract well, that may lead to urinary retention. And another very unfortunate situation might be, yes, impotence, right? That autonomic nervous system is disturbed to the male organ, and that may damage so much that blood flow to the male organ is altered so much that erection cannot be maintained for appropriate penetration, right? I don't know much about inappropriate penetration, but anyway. So what I say that it can produce impotence also. This is one complication in the diabetic patient which as a doctor you should ask, but please ask only men, right? Because usually they are shy to talk about. You know, there's something very strange. Women find it easy to talk to their doctor about their urogenital problems. Men feel more difficulty to talk about it. You know why? Because due to periods and their irregularities and pregnancies, and due to other gynecological reasons, women are more used to talk to the healthcare provider about their problem. Because men are not so regularly going through such processes, so once they develop impotence or anything like that or some problem, they find it very difficult to talk to the doctor, right? So this, as a doctor or as a nurse, you should inquire male patients who are diabetic if they have problem related with urogenital system or not. So what I wanted to say that it can produce macrovascular complications. It can produce microvascular complication. We are still passing through an introduction to diabetes mellitus, because in coming lectures I will go in detail of, there will be lecture only on diabetic neuropathy, its management, its clinical features. There will be lecture only on what? Diabetic nephropathy, its clinical features and its management. There will be hopefully lecture, complete lecture on diabetic retinopathy, its progression, its stages, its causes and its management. Right now I am just trying to tell you how bad is diabetes. Diabetes is everything sweet is not sweet. Diabetes mellitus. Diabetes means lot of urine is coming, and mellitus means sweet. But every sweet thing is not necessarily too good. Diabetes mellitus is one condition that we can say this is sweet diabetes. Unfortunately, it's a monster. With death string, what was that? Hyperglycemia. Two ends of the death string. Type 1 diabetes where less insulin is produced or no insulin is produced, or type 2 where at least initially insulin is there, but there is more resistance to flow. And then there are many other death gems inside, like type 1, then there's type 2, then there are LADA, latent autoimmune diabetes of adult, or there is MODY, that is maturity onset diabetes of young, right? Then there is in between secondary diabetes. There are so many causes, we will talk later. I will of course discuss, there will be a full lecture on pathogenesis of type 1 diabetes, and there will be another full lecture on the pathogenesis of type 2 diabetes, and then there will be another lecture for the pathogenesis of rest of the types of diabetes, right? But what I was saying, that in between type 1, type 2, then there is, yes, LADA and MODY, and then there is secondary, and there are gestational diabetes, and many other which are less common, we will discuss later, right? We have a lot of time. Then I told you that I didn't tell you the general clinical features of diabetes, but I wanted to tell at least complications which I mentioned, that this disease is so dangerous that number one, I feel personally it is more dangerous than corona. Corona either kills you or leaves you. But this disease, if comes once, it keep on staying with you, sometimes lifetime, and it has so many different ways to kill you, and it kills inch by inch. Today you are going for the foot complication, maybe after 2 days you are going for renal complication, maybe after 5 days you are going to ophthalmologist for retinal complications. It's a very sad story, and unfortunately this disease is so rapidly spreading that some authorities believe that 10% of the adult population in the world is suffering with this disease, every 10th person. And in some countries, in the adults, every 5th person is having diabetes mellitus. But why this diabetes mellitus is getting so common that in some regions of the world it is spreading in people as if it is an epidemic? Thanks God it is yet not pandemic, but it has already achieved a status of epidemic. Why? Few reasons which are mentioned are lifestyle changes, right? For example, now our nutrition is not as healthy as it used to be in the 100 or 200 or 500 years back, right? Processed food, more sugars. Then not only nutrition is not healthy, then our physical activity is reduced. If you are very rich, even you don't want to open the door of your car, I think you love to have diabetes, right? For everything we want remote control. We don't want to do exercise more than the thumb muscles. So this is very sad. So overeating of calories and taking the processed food at the top, reduced physical activity, and then aging population. We refuse to die because there is so much medical care available that we keep on lingering with the life, right? So aging population, right? So aging population, nutritional abnormalities, reduced physical activity, and what else can be there? Maybe the stresses of modern life, right? Some people say that why modern life has more stress. I say it's very natural. If you are living in a village and all your life you spend in a village 500 years back, you know about 100 or 200 people, right? But when you are living this in global village where so much technology, someone dies 20,000 kilometers away, it might have stress on you. And in the morning in a big city, if you move, commute to your job, maybe you see on the way 5,000 faces, human faces, and we learn to ignore them, and that adds to the stress. So there are so many modern stressors also which are added to our life, right? So all these things together have disturbed our metabolism because we are not designed to sit and read the medical books. We are not designed to sit and pass the medical exams. We are designed to live in a jungle. Either we are running after smaller animals or bigger animals are running after us. Right? Yeah. That is more natural life for which our metabolism and our whole system is developed. Right? I was telling few days back that physical activity is very important. Right? It is so important that now doctors have discovered and researchers have discovered even your walking can produce neuron growth factors. Neuron growth factors, because all sensation and proprioception going to the central nervous system is telling you might be you are walking in the jungle. You know, our body is not evolving so fast as fast the technology is evolving. Right? And your central nervous system should be more alert. And what happens? Not only it produces endorphins, it produces growth factors in the central nervous system. Right? So what we were talking about, now we come to some miscellaneous complications. Right? Which I mentioned, there was gastropathy. And in gastropathy, what is contributory factor? There are multiple reasons for gastropathy, which we will discuss later. But one of the, yes, you have a question.
Sir, neuropathy is the problem with neurons. So neurons are neurons, these are not blood vessels. Why we are saying that this is a problem with microvascular?
Okay, he has come with the question that neurons are neurons and neurons are not blood vessels. So why we are saying that neurons are having microangiopathy? You must know that neurons also have microvessels, not neuron. Actually, nerves have small vessels. There are vasa vasorum going into nerves, and vasa vasorum divide into millions of capillaries. And those capillaries which give nutrition to the neurons, neurons use a lot of nutrition, right? And those capillaries develop advanced glycation products, and that can lead to the trouble, right? So let's come forward, and we were talking about, yes, other complication. Gastropathy we have already discussed. Then there can be cataract. Cataract. Please don't tell anyone that cataract which develop in diabetic patient, right, that is due to microangiopathy. That was retinopathy. Cataract develop due to basically patient with the diabetes, especially with the uncontrolled diabetes, having very high repeated spikes of hyperglycemia. Why do they develop cataract? One reason is that when hyperglycemia occur, lot of glucose enter into lens, and there this glucose is converted into sorbitol. This glucose is converted into sorbitol, and this sorbitol which accumulate in the lens, when later on listen now carefully, later on when hyperglycemia go to normoglycemia, sorbitol is trapped in the lens and it cannot come out, and it produces osmotic effect. And when sorbitol is there, and again hyperglycemia, lot of glucose enter into lens and convert into sorbitol. When euglycemia occur or normoglycemia occur, sorbitol cannot leave the lens, and this accumulated sorbitol within the lens pulls the water, and this sorbitol and water plus glycations, all of them damage the lens normal collagen and normal proteins, and which become opaque because they disrupt the special arrangement of collagen in the lens and special arrangement of proteins in the lens which keep the lens transparent. So lens become parts of the lens become opaque. So we say cataracts develop, and these are also diabetic cataracts. Are if you develop diabetes at early age, then this will be pre-senile cataract, right? Then it can produce not only cataract, this can produce glaucoma. Yes. What is glaucoma? Glaucoma is pathological increase in intraocular pressure. You know, okay, let me draw a eye here. Yes. This is your cornea, iris. What is this? Ciliary body. And what is this? Choroid. Again, what is this? Ciliary body, and there is iris. And in between here is pupil. As you know, this is cornea, right? That at this angle in the trabeculi, this is a system to drain the aqueous humor, right? At this angle in trabeculi, two types of problem can occur. Number one, advanced glycated products, and trabeculi, yes, trabeculi become thick and drainage slits become narrow and you develop glaucoma. Drainage system is blocked. Why? Because there is abnormal glycation. Number two, there can be neovascularization here. Pathological new vessels develop here, right, at the drainage angle, and aqueous humor cannot drain, and that leads to what? Raised intraocular pressure. So, if someone asks you what are the ocular complications of diabetes mellitus, yes, a good doctor will say diabetic retinopathy, then some better than good doctor say cataract also, then super good doctor will say glaucoma can occur. Then there is excellent doctor who will say even damage to the muscles which are controlling the movement of the eye, damage to the abducent nerve, damage to the oculomotor nerve. So there are so many complications of diabetes related with the eyes, right? After this, glaucoma, we can come to your favorite thing, why infections are more common in patients with diabetes. Okay, this is very important question. We will have a full lecture on it, but right now a little introduction. Why infections are more common in patients with diabetes. I would love to explain this in reference to diabetic foot. Even though these patients develop infections in many areas in the body more frequently as compared to the normal population. But right now, I will specially mention the infections in the foot. Now, in diabetic foot, why infections are common? Some reasons are very clear. There is neuropathy. If there is sensory neuropathy, of course, they will hurt or damage their foot, and they will not knowing it. And through that injury point, infection can enter. Number two reason can be that motor nerves to the foot and muscles are damaged, and due to that reason, abnormal mechanics of muscles and joints and the bones interaction produces abnormal pressure point, and that may produce ulcers, and those ulcers expose foot to the infection, right? So neuropathy is there. Then more infection in the foot. One more reason is vasculopathy, that there is reduced blood flow. If there is reduced blood flow, it means less nutrients are coming for the repair, and less immune components are coming, less antibodies, less neutrophils, less monocyte or T cells or other defense mechanisms or complement factors. So, due to vasculopathy, what is happening? Number one, again, it's worth concentrating, because many people very unfortunately undergo what is this? Non-traumatic lower limb amputations, right? There can be sensory component which is disturbed, so they get more injuries. There might be motor system disturbed, Abnormal pressure points may lead to ulcerations and more infection chance. Then there is vasculopathy, reduced blood flow, foot becomes ischemic, and that lead to reduced nutritional supply for the healing and reduced immune components to fight with the infection. This is generally, but let me tell you more specific reasons that even a person develop otitis externa or he develop boil hair and it is not healing, rather infection is spreading. Why it is happening? The reason being there is severe, if diabetes is uncontrolled, there is severe dysfunction in immune system. Look at the red blood cells, not red blood cells, sorry, neutrophils. Neutrophils, if there is too much glucose they take up, they just like become drunken men. You have seen drunken men? They are I think you must have seen it, right? You have been with your friends. They keep, sometimes at midnight, they are moving in the streets and they don't know where to go and what to do. Same thing happens with the neutrophils. They are drunken with the oversupply of glucose. And this oversupply of glucose to the neutrophil produces dysfunction. These drunken neutrophils, they don't stick to the endothelium. They cannot knock at their door. They don't know where is the door, where is the house. So where there is infection, they cannot stick there. Then even if they stick there, they are very poor in chemotaxis because increased glucose is disturbing all motor proteins which are responsible in the neutrophil for chemotaxis and movement. Look at it, drunken man wandering in the blood vessels. First he doesn't know where the endothelium he should stick, knock his door, and even if he reaches door, unable to enter and go to the bedroom. Here the bedroom is where the infection is, no chemotaxis. It's so drunken. And it's so drunken, even you put something in the mouth, phagocytosis, they are unable to eat, whatever you put they drool out. So these neutrophils are having less stickiness with the endothelium, they have less chemotaxis, directional movement towards the focus of infection, they have less ability for phagocytosis, and even if they phagocytose something, they have less ability to kill that organism, which is microbicidal activity. That is also reduced. So what happens? That if you are a diabetic patient and your blood sugar is unfortunately not properly controlled and your neutrophils are always drunken and happy with this so much glucose, they are going under multiple malfunctions, failure to stick with the endothelium in the inflamed area, failure to do chemotaxis, failure to do the phagocytosis, and even if do the phagocytosis, failure to what? Failure to kill the organisms. All these things increases our chances to suffer with infection. And then even macrophages also become drunken. I mean monocyte, when monocyte move out of blood vessel into inflamed tissue, we call them macrophages. They become so drunken that one of their important function they don't do. That important function is to produce the cytokines, to call more neutrophils and call the lymphocytes. If I am a monocyte, I should slip out of blood vessel in area of inflammation and I should go into tissue and you should change my name to macrophage and then I should start giving cytokines. Cytokines are just like calls to more neutrophils. It's very interesting. At the site of inflammation, neutrophil produce the product which call macrophages and macrophages produce the product which call neutrophils. So they are calling more forces, but these macrophages go and sit there, forget how to do phagocytosis and forget to call more neutrophils and forget to call more lymphocytes. So lymphocyte dysfunction also develop. All such dysfunctions lead to increased chance of infection. So what I was talking about, that unfortunately in these patients infections are very common. So unfortunately, not only baby, some even microbe also love the candies, sugar loving microbes. And patient with diabetes, these sugar loving microbes, glycophilic microbes, they are in paradise, right? Why they are in paradise? More sugar to enjoy, and all the neutrophils which want to kill them are themselves drunken, and all the macrophages forget to call the forces, and microbes are proliferating, right? So there are so many reasons, unfortunately, in these patients with diabetes to undergo multiple infections, and their infections, they develop infections more easily, their infections spread more, and they heal very poorly, right? And this I will add to the diabetic foot also, that due to neuropathy and due to vasculopathy and due to this failure of immune system or our neutrophil and macrophage system, this all lead to more and more infections in the foot. Diabetic foot will lead to that condition, but we will talk about that later in detail, right? So what we have talked about, diabetic foot, then of course it can even lead to, do you think it's going to excuse you this disease? No. It is not only after your eyes, this disease can be after your ears also. If you ask a good doctor, what are the complications related with the ears of the diabetes, the good doctor will say otitis externa. More good will say more frequency of otitis media also. But there are super good doctor. He will say, of course, otitis externa is more common. Of course, otitis media is more common. But don't forget, 8th cranial nerve, vestibulocochlear system, right? Vasculopathy occur there also. Those nerves also suffer with microangiopathy, and sensory neuronal deafness may occur, right? So what is happening, that these patients have macrovascular complications, they have microvascular complications, they have many extra complications like gastroparesis, uropathisis, dermatological complications, of course more infections, and blood vessels in the skin also suffer with angiopathy, right? Then they have more infections, they can have cataract, they can have glaucoma, diabetic foot, and hearing loss, even periodontal disease is very common in them, because at the junction of, what is this, teeth and gum, in those crevices, many microbes love to proliferate, and our defenses here are very weak, right? So many different types of problems can occur in the patients with diabetes mellitus. And before I conclude this lecture, I will again say there are so many things which are contributing to diabetes in modern era, especially type 2 diabetes is becoming very common. Why? More obesity, less physical activity, more industrialization and automation, right? More aging population, and of course there are more stresses there, right? All these things lead to development of type 2 diabetes more commonly in populations, right? And another thing which I want to tell you, you know what is that? Most of us think that diabetes is a disease of rich countries. Yes, there was a time this disease was the disease of rich country, but now even many countries with you can say mid-range income or low-range income, they are also developing diabetes very rampantly because of changes their habits, right? And I think I should take a break now. This is enough. After the break, we are again going to meet, and it was just an introduction to diabetes. Never forget, if someone say that a person has diabetes, make it sure he has a tendency for chronic hyperglycemia. That is the common thread, okay? Class dismiss for a while. After some time, we will again talk. Class dismiss. Thank you, everyone. Thank you.